relay their questions. Um, let me call call Honorable Folashade Small to give us an opening prayer. Please, Honorable Folashade Small.
Blessings.
Blessings, ma'am.
Father, we thank you. We glorify your holy name. We praise you, Father, for this great opportunity to learn, to hear, and to make good use of it, and to be able to educate others. We thank you for our wonderful speakers. We thank you for all the organizers. We thank you for everyone here today. We say, Lord, that you take all the glory. You help us. You guide us, even though we know that everybody has a cancer cell in them. We ask, Lord, that you help us and give us every knowledge we need to know everything. And we thank you for this section. Take all the glory, Lord, as we go into this section, and let your name be glorified. In Jesus' name, amen.
Amen. Oh, thank you very much, Honorable Folashade Small. Good morning, all. Good morning, everybody. Here with us, I have Dr. Eric Maya, from Capital Health Urology Specialist, Director of Capital Health Urology Specialist, Director of Urologic Oncology and Robotic Surgery. Dr. Eric Maya is a board-certified urologist with expertise in treating all forms of urologic conditions in addition to specializing in minimally invasive robotic-assisted urologic procedures using the Da Vinci surgical system. Dr. Maya received his medical degree from UMDNJ Robert Wood Johnson Medical School in New Brunswick, New Jersey, where he also completed his urology residency. Before joining Capital Health, Dr. Maya was Chief of Urology and Minimally Invasive Urologic Surgery at St. Luke Center for Urology, part of St. Luke University Health Network. He is the first surgeon in Pennsylvania to perform a robotics-assisted laparoscopic prostatectomy using the Da Vinci surgical system. Fluent in German, Dr. Maya volunteers for international surgical missions in his spare time and also enjoy running, skiing, mountain biking, auto racing, and model building. He's a member of the American Urological Association and the American Medical Athletic Association. Thank you, Dr. Maya, for being here today. We are happy to have you.
Thank you so much. Yeah, thank you. Yeah. And before I begin, actually, I'm just curious if everyone could see my slides. I had sent a deck over this morning. Otherwise, I can try and share my screen since we're on Zoom. This always takes a minute to set up. Let me just see if I can do that. Let's see here. 2. All right.
Oh.
Let's see. Can you see the screen now with the slides?
Yes.
Yes, sir.
Excellent. All right. Yeah, I just wanted to make sure I had this right, of course. Yeah.
And doctor, before you start going, sir, I would like to mention that the president of Eko Club Philadelphia, who is in charge of the organization, is here with us, Honorable Mrs. Olabisi Dabiri Okoya. So just want to let everyone know that she's right here.
And she's here as well. Oh, that's wonderful. And thank you all for having me this morning. I really appreciate the opportunity. In terms of the work that I do, I'm on a number of committees that, look at cancer statistics and outcomes in patients. And, one of the things I've noted over the last few years, and probably in part this is due, to the COVID pandemic that we all suffered through, is that I am seeing an increase in patients, manifesting or showing up with advanced stage prostate cancer, especially in the African American population and in the underserved communities. And so one of the things I wanted to discuss today a little bit has to do primarily with where things stand in terms of our current recommendations and guidelines and sort of thought processes as it relates to screening for prostate cancer, because there is a lot of confusion out there, in part because even on our end as clinicians, we're always learning about the conditions we treat, and a lot of this has really evolved and changed just in the last few years. So hopefully at the end of this, it'll make a little bit more sense in terms of how we approach this problem nowadays. And I'm just going to see here if we can go ahead and move ahead. All right. Can you see that next slide? I just want to verify everything is working okay.
Yes.
Okay, great. All right. So I'm going to go ahead and just move ahead just to give a little bit of a background in terms of, how prevalent or how common this disease is in the United States. Roughly 175,000 cases are diagnosed every year, and it represents almost 10% of all cancers that are diagnosed in the United States. And people oftentimes, talk of this disease as being slow growing or something that doesn't pose a risk to your overall health. But the reality is that, even in this country, roughly 32,000 people, die every year from this condition. And it actually represents, roughly 5% of all patients that succumb to cancer in general. Importantly, and this is at the bottom of the slide, you can see that there's a much higher incidence or a much higher likelihood of developing prostate cancer in the African American population. And that really just stems from underlying genetics. I like this slide. This is a very old slide, but it kind of demonstrates a little bit about the history of the PSA test. Now, the PSA test is a simple blood test. It can be done just as part of routine blood work. I'll get into the recommendations as to how often that ought to be done. But the reason I put this slide here is that it's a good demonstration of the impact of that blood test in terms of the diagnosis and ultimately treatment for prostate cancer. And what I mean by this is that if you look at this slide, in the late 1980s, roughly the time I was in medical school and sort of completing my training, the PSA test became available nationwide. It was started to be used more or less as a screening tool. And you can see in the years that followed, especially going into the, let's say, mid-1990s, that there was a huge spike in terms of the diagnoses made. And the reason for this is that essentially that test was allowing us to play catch up in finding patients or detecting patients that had prostate cancer that was otherwise undetectable on examination. And so we shifted the bar, if you will, a little bit earlier and picked up, this much larger group of folks that actually had the disease and really didn't know that it was there. The other interesting thing in this graph is if you follow the timeline at the bottom out, let's say towards 2010, 2014, is that you can see that even though there was a huge increase in terms of the number of diagnoses being made, the impact in terms of survival and death from the disease was a delayed improvement. So that purple line at the bottom, you can see only begins to trend downward some years after this large increase in terms of patients that were diagnosed. So there's more to this story, unlike other cancers, which can be very aggressive and manifest quickly. This one tends to play out at least over a longer period of time. Very important detail, especially when we talk about data or when we talk about outcomes for any type of treatment. You really have to be able to follow people for an extended period of time. And so this gets into the overall debate of PSA test use and, its appropriateness overall. Basically, in terms of the larger research and studies that are out there, especially in the early years of, the use of this test, the realization was that you would have to screen about 1,000 men in order to prevent about 1.3 deaths. on the other side of the equation, in terms of preventing advanced prostate cancer, meaning cancer that's outside of the prostate and other parts of the body, basically here you would prevent 3 of those cases for every 1,000 people that were screened. The issue with screening, at least as it used to be up until maybe about 5 years or so ago, is that once someone had a positive PSA test, meaning a blood test result that was concerning or worrisome potentially for a prostate cancer, the only way to establish that diagnosis beyond that was to do a procedure called a transrectal prostate biopsy. This is actually still done in other parts of the country, but I'm glad to say there are actually newer techniques that make this process safer. The issue with that biopsy and that form of approach is that it usually involves needle sampling of the prostate through the rectal wall. So it's done from behind, which in turn carries a risk anyway of bleeding and infection in that environment. And so the complication rate of a prostate biopsy historically is about 3%, with about 1% of patients needing hospitalization, usually for a severe infection. The other part of this, knowing that, a lot of men need to be screened in order to save a few lives, is that a number of men, or a sizable number of men, ultimately would also be diagnosed with prostate cancer and undergo treatment for prostate cancer, even though the disease itself may not have affected their overall survival or their overall health in the long term. And that's not insignificant in that, treatment of prostate cancer, especially in the 80s and 90s, used to be either earlier forms of radiation, which would carry a lot of side effects in terms of urinary symptoms or affecting impotence and the quality of erections. Or we used to do open surgery, so a big kind of large abdominal operation, which carried a pretty large risk of either bleeding or a 5% risk of permanent incontinence, loss of urinary control, aside from erectile problems. And so it's for that reason, actually, that I help kind of move on or develop surgical approaches to do this robotically, because the side effects are substantially less with that approach. And in today's world, it's very rare nowadays, actually, that anyone does an open prostate surgery. As far as the history is concerned, screening for prostate cancer and undergoing treatment for the condition, would reduce the death rate by about 20%. But in order to reach that statistic, you would have to treat about 30 to 40 people in order to prevent one death. And you can see just on the basis of that, that it gives rise to legitimate questions in terms of, whether or not screening is useful and beneficial overall to a population, and whether there's anything else we can do better to help kind of shift those statistics more favorably. And so this is a kind of a simple slide, talking about basic statistics, which I never liked, but in any case, when it comes to PSA testing for routine purposes, we consider a PSA of 4, so a result of 4 or higher, as being abnormal. Meaning that individual needs a closer look in terms of potentially having prostate cancer. The key thing to understand about this blood test, though, is that it isn't perfect. And I always tell people, I use the analogy that it works like an engine warning light in your car. That light goes on. It's an indicator that something may be happening, but it doesn't necessarily mean that the engine itself is shot. And so what I'm trying to say with this is that when I see patients for an elevated PSA, the most important thing I can do is actually talk to them and get a little bit of their background history. For example, any form of infection or inflammation in your system can at least temporarily drive those numbers up. And so, seeing someone, let's say, that recently had a cold or a pneumonia or underwent a surgical procedure, oftentimes, what I'll do in that scenario is just wait a little bit, repeat the test, and see if it trends back down to normal. And so here again, it's a simple way of trying to avoid unnecessary testing, until actually the diagnosis or the PSA trend itself is confirmed. As far as the test utility is concerned, its sensitivity, meaning its ability to find prostate cancer, is about 75%, which means that it could potentially miss about 20 to 25% of prostate cancers as well. And it's for that reason that most urologists usually do a rectal exam as part of the screening, because there are occasions in which we get a normal PSA result, but we feel something abnormal on the prostate. And in and of itself, that could be a harbinger of having the condition. The other statistic is specificity, meaning the accuracy of a negative result. And what that means is that, for somebody that has a negative PSA, there is still sometimes a potential risk of upwards of 40% of having prostate cancer. And so the way we work around this in terms of screening recommendations to help make this more accurate is that we typically recommend that this process, meaning the PSA test, be done once a year. And the rationale for that is not only the number in terms of what we're looking at, but the rate of change in these numbers oftentimes paints a more accurate picture as to who may be at risk. In someone that has a consistent PSA result that's anywhere between 4 and 10, the probability of having a prostate cancer is about 25%. And so on the kind of basis or the background of what I've been discussing in terms of, the large number of patients that need to be screened or biopsied in order to diagnose prostate cancer, and the large number of men that need to be treated in order to prevent one potential death from the condition. A lot of large population studies were done in the late 2000s that basically tried to answer the question in terms of, whether or not PSA screening was actually a useful tool, or, perhaps that there are other considerations that need to be brought into light. And so the first of these studies, which turns out actually to be the most accurate study, is a European study on prostate cancer. This was published at first in 2009. And the basis of that study in Europe was basically to screen men at several year intervals with PSAs and to biopsy accordingly if there is a PSA increase and subsequent treatment in those patients as necessary. Around the same time, here in the United States, a study called the PLCO, which is prostate, lung, colon, and ovarian cancer, kind of a large study that looked at multiple cancers and screening, was also published. This study was a little bit flawed in the sense that in those patients that underwent PSA screening, a lot of men that were subsequently diagnosed with prostate cancer kind of fell out of the study. So it kind of shifted the bias of the result a little bit away from prostate cancer screening. The other element, too, is that when this was published in 2009, this study at that point in time was only about 7 to 8 years old in terms of its maturity, whereas the European study was upwards of 12 years out. And if you recall that earlier slide that I showed you, with the delayed impact in terms of death and mortality from the disease, you can see that, the timing of these studies and how that result is interpreted can have significant impact. Nonetheless, in 2012, the U.S. Preventative Task Force, which is this entity here in the United States that basically looks at existing studies and makes recommendations about screening for various cancers, basically gave prostate cancer a grade D. Meaning that PSA testing and screening for prostate cancer really is unnecessary and that it hasn't been shown to provide any benefit. And I can recall when this study was first, introduced and got picked up in the media and the stories and the presentations that were all over the news and so forth, basically dissuaded people, from getting prostate cancer screening performed. It was a pretty chaotic time, primarily because in the cancer groups, people like the American Cancer Society and so forth, were really opposed to that recommendation, again, because they were looking at data over a longer stretch of time. And I'll demonstrate exactly what their points were here in a moment. But there was a lot of turmoil, I should say. And as the result of this was, Medicare and a lot of major insurers stopped covering PSA testing for cancer screening. The family practice organizations stopped screening patients for prostate cancer as well. And as I'll show you, unfortunately, that did have impact in terms of outcomes later on. I'm glad to say that in 2018, the USPTF revised their guidelines, based on existing data. So they kind of dialed this back, if you will, and now have recommended that men between the ages of 50 and 69 consider prostate cancer screening. And so to kind of put this in a graph form, this is that European study that I was talking about at first. And if you can see, along this graph here, along the bottom, years since randomization, if you notice, it's only once you get past year 10 that the screening group, that is the blue line, began to see a benefit in terms of death from prostate cancer. And so the takeaway here, yet again, is that, to have an impact in terms of this screening process, generally it's going to be 10 years or more before we know for sure if in fact we're having a positive effect. That PLCO study in terms of later analysis and sort of going back on that patient population also mimicked this result. And again, it explains kind of why the USPTF basically walked back their initial recommendation. And you can see this actually did have an impact in terms of that 2012 recommendation. Certainly had impact here in terms of its effects on the United States male population. And specifically here, if you see in 2012 when that guideline is released, that key age category, the 50 to 69-year-old gentlemen, there was certainly a drop-off, in terms of people that are being screened. That manifested itself out. Oops, let's see if I can go back. Looks like I skipped ahead. But what I meant to say is that, or demonstrate in that earlier slide, was that there actually was a drop-off in terms of screening population-wise. Net results, which we can see on this slide, is that screening for prostate cancer, during this time frame in the United States, dropped by as high as 39%. So a pretty large drop. Overall prostate biopsies dropped by about 20%. So 1 in 5 essentially were reduced. And what we were beginning to see is that grade 1 cancer or Gleason 6 prostate cancer, which is the earliest and slowest growing version of prostate cancer, was no longer the most common diagnosis. What that's saying is that in those patients that wound up going for biopsy and being detected with prostate cancer, there was a shift towards more aggressive disease. And that's also confirmed basically in the number of men that were subsequently showing up with disease that was elsewhere in the body and outside of the prostate. And that actually went up by about 5%. The problem in this scenario, and the reason why this is so important, is that while we have treatments for metastatic disease, hormonal medicines, and certain forms of chemotherapies and the like, none of that is a home run. And so once you have metastatic disease, the issue now becomes one of trying to control the process as opposed to curing the condition. So the big question in all of this is, knowing what we know about the population at risk for prostate cancer, knowing that at least in the early days of PSA screening, that without question, a large number of men were being screened, tested, and treated potentially unnecessarily. The question then comes, okay, can we do something better? Is there a way of looking at this issue in such a way that we narrow that population safely and only screen and treat those men that are going to be at highest risk? And the short answer to this is yes, we certainly can. First off, we should only screen those individuals that would have a true survival benefit in terms of detection and treatment. And so as a general rule, we usually recommend PSA screening in men that have at least an expected lifespan of 10 years or more. So to put it another way, if I have, let's say, an 80-year-old person in my office that I'm seeing for unrelated urologic conditions, I typically wouldn't recommend PSA screening and most definitely not prostate cancer treatment in that individual given their projected lifespan. The other aspect, as I kind of touched on before, is to interpret PSA results carefully, meaning, you should understand your patient, their clinical history, the context in which that test was performed, to make sure it's an accurate representation of what's actually going on. As I mentioned also, we should repeat the test in many cases and also look at the rate of change in those PSA values over time. Another trick we sometimes use is something known as the PSA density, which is basically the PSA test result divided by the volume of the prostate. So if we have imaging like an ultrasound or a CAT scan where we have a measurement of the prostate volume, we can do basically a quick calculation, which helps guide us also as to whether that person may be at risk. This is a complicated slide, which I'm basically going to try and simplify, but it gets to the point of, no longer being a shotgun approach in terms of how we screen men for prostate cancer. The key category here, the things that I would want to stress, is that anyone that is either African American or with a family history of prostate cancer ought to consider PSA testing and prostate cancer screening from upwards of age 40 to 45. Okay, and again, it's just because that particular subgroup of individuals is at a much higher risk of potentially developing the disease. On the other end, as I kind of touched on before, once you get past 70, unless you're in excellent health, we begin to scale back in terms of cancer screening overall. The other good news I have is that we have newer tools in terms of additional prostate cancer screening possibilities. As I touched on before, in the early days of all of this, the only option we had in screening was to do what's known as a transrectal biopsy. In today's world, what we do instead is a multi-parametric MRI. This is a very new technology. It's only been in clinical use for about 5 years or so, but it's a non-invasive way of taking a closer look at the prostate. This has a number of benefits. It's non-invasive. The MRI basically generates a roadmap of the prostate, and it highlights any potential areas of concern. So the first benefit here is that if the test returns normal, it actually allows us to at least avoid a prostate biopsy. And so far, it's been shown to help us reduce the number of biopsies that are necessary by at least 40%, which is great news, pretty significant in that respect. The other benefit, and this is especially important in men that have larger prostates, is that if we detect an area of concern, when I now do a biopsy, what I do is something known as a fusion biopsy, where we basically merge the MRI imaging live time with the imaging I'm getting in the operating room, which guarantees that I sample those areas of concern. And you can imagine someone with a very large prostate, in the past, we would be kind of shooting in the dark or flying blind in terms of finding their cancer. This allows us to target those regions, basically looking for those aspects or portions of the gland that may be a higher likelihood of harboring disease. So this has really changed the landscape quite a bit in terms of what we're doing nowadays, reducing the number of biopsies, yet at the same time enhancing and improving our diagnoses in people that are at risk. The other trick that we're doing nowadays, and this is my routine approach now, is that we no longer do the biopsies through the rectal wall. Instead, we do what's known as a transperineal biopsy, which means that instead of introducing the needle through the rectal wall, where there's bacteria, of course, lingering, what we do instead is we do the sampling through the skin directly onto the prostate from behind the scrotum. The advantage here is that it's reduced the risk of infection by at least 5 times, and there is a less than 0.5% risk of sepsis. And in fact, it's changed things so much that I don't even need to give antibiotics as much as I used to previously, which has other safety implications as well. The other aspect which has changed, let's say in the last 10 years, is that we no longer treat prostate cancer as a one-size-fits-all approach. So if you remember my slide, with that big spike in the early days of prostate cancer diagnoses, if you had the condition at that point in time, you were treated either with surgery or radiation, and it really didn't matter what form of prostate cancer you had. because the thought was that left untreated, it would pose a risk at some point in terms of being able to spread to other parts of the body. We now stratify the risk basically by looking at the cancer cells under the microscope. We use something called the Gleason score. It's a number score that ranges from 2 to 10. 10 is a highly aggressive cancer, while the slow-growing versions are usually Gleason 6 or less. On top of this, nowadays, we also have additional genetic testing that we can do to these samples that help give us a better profile as to, how aggressively that condition may develop or manifest. The point of all of this, though, is that for patients that have low-grade prostate cancers, instead of treating with radiation or surgery, what we do nowadays is something known as active surveillance. And what that means is that, we're not just ignoring the disease, but we have an algorithm that we follow in terms of sequential PSAs and PSA monitoring. And usually, periodically, we either repeat the MRI or the biopsy every several years just to resample the cancer to make sure that its aggressiveness hasn't changed. The wonderful news with this, of course, is that it greatly reduces exposure to the side effects of prostate cancer treatment. And actually, it's reduced the overall need for upfront treatment by at least 50%. All right, so of course, that's going to have a lot of positive impact without sacrificing someone's outcome if the disease were to change in the future. And so in today's world, sort of the standard recommendations in terms of where we stand, as I discussed earlier, our overall need for prostate biopsies has been reduced by about 30 to 40%. We've reduced morbidity or side effects of prostate biopsies, especially as it pertains to infection and bleeding. We furthermore reduced the need for upfront treatment, at least in patients that have favorable forms of prostate cancer. And as we touched on in terms of the actual techniques that we employ, the standard for those needing surgery nowadays is robotic surgery, which carries a less than 1% risk of incontinence, which is a major improvement from open surgery. Our radiation techniques have evolved immensely. I used to say that in the past, when you had radiation, it was like a car headlight shining on you from one direction and everything in its path, was irradiated. The newer techniques kind of work like a magnifying glass in the sun. So we take lower forms of energy, but we're actually able to concentrate more energy onto the prostate. So the interesting thing is that we're actually able to treat the prostate itself more aggressively, while at the same time reducing exposure to everything around it. So the landscape has changed quite a bit there as well. And again, in terms of overall cancer screening recommendations, so this is for all men. Generally, we advise screening between the ages of 50 and 69. We advise earlier screening from ages 40 to 45 upward in patients that either have a family history of prostate cancer, African American lineage, and certainly a greater than 10-year life expectancy. Thank you again for allowing me to speak this morning.
Thank you very much, Dr. Eric. Is that the end of the lecture?
Yes, it is. Yeah.
Okay. Thank you very much, sir. We really appreciate you.
Yeah.
I think some people have already started sending in questions. If you have a question, you can raise up your hand or send it through the chat, the group chat.
Yeah, I think I do see one question that came through earlier. I'll just read it to the group. It asks specifically what the effect of prostate cancer is on erections and ejaculation. Excellent question. In today's world, most prostate cancers, again, are found because of the PSA test, as opposed to something that we feel on the prostate itself. And what I'm driving at is that, typically these cancers are pretty small within the prostate. And so they typically do not manifest in any symptoms at all. They don't typically affect urination or the quality of erections. It's only at the later stages of disease, if the disease has really progressed beyond the prostate or through the prostate, that it can begin to cause those symptoms. Yeah.
Okay. And another one is right here. It's why is it that when you are 70 plus, PSA tests are not necessary or treatment necessary?
Yes, excellent question. Yeah, and it gets back, to a lot of the statistics that I went through, and the balance that we're trying to strike in all of this is that we want to screen people appropriately for the condition, but at the same time, we don't want to overtreat people or expose people to the side effects of treatment unnecessarily. And so in, the setting of somebody, let's say that's 70 or more, there are occasions where I still screen people. For example, somebody who's very healthy, history of longevity in the family where their parents, let's say, lived into the 90s or more, where reasonably speaking, there may be a 10-year or greater life expectancy in that individual. I do consider screening in that particular circumstance. But with the average lifespan in the United States of being in the early 80s, for the average patient, somebody with other medical conditions or a projected lifespan of less than 10 years, there really isn't much benefit in screening and would arguably cause more harm.
Then another question is how often do you recommend colonoscopy in my mid-60s?
Yeah, that's a good question. Now, this this gets a little bit outside my area of expertise. That's usually done by a gastroenterologist. But the standard recommendation usually is to have had colonoscopy at least one time from the age of 50. Assuming that's a negative colonoscopy, I believe the current guidelines recommend repeating that at 10-year intervals.
Okay.
Um,
We have when the PSA number is high,
yeah,
that is more than 12, what action are we supposed to do?
that's an excellent question. And that definitely is a PSA where, that engine warning light that I speak to is on. That warrants a closer look. And so in that situation, I would say without question, you ought to be examined by a urologist, having the prostate checked, trying to see if there's anything that's actually palpable or that we can feel on the gland. Typically, I would repeat the PSA also and potentially move forward with an MRI afterward if that PSA is persistently high. So that would be an indication to move forward, with the screening process that I outlined.
Okay, thank you, sir. Then this question is this is another question here. Does diet and lifestyle influence prostate cancer risk?
Yeah, excellent question. So in terms of diet and lifestyle, when it comes to this cancer, at this point, there aren't any smoking guns in terms of dietary risk. There are some studies that suggest maybe a higher fat content in the diet or the consumption of processed foods may slightly increase the risk of developing prostate cancer. However, what we do know in terms of prevention, protection from prostate cancer, hydration, keeping the urine as clear as possible is a good one because that lessens chronic irritation in the urinary tract, which has been associated with cancer development. We do recommend tomatoes or tomato-based products. Specifically, that has something called lycopene, and that may be of some benefit in cancer prevention for the prostate. And I typically also recommend a multivitamin, just a standard men's multivitamin. It has a lot of the trace elements that may be of some use as well.
All right, before we go to our questions on the chat, there is Mr. F.A. Ade raising up his hand. Can you unmute yourself, sir, and ask your question?
Yes, sir. Thank you so much. My name is Fatai Adeshiji.
Oh.
A follow-up question to the first one about the effect of prostate cancer on erection and ejaculation. You said it's not almost no action, no so much effect. But we are told that if you are wearing tight underwear, tight pants, that it can, induce or let you be prone to having a prostate cancer. How far is that true? And also, is there any remedy aside from going for this treatment that one can take, like, traditional remedies or some herbs or things that somebody can take if they have prostate cancer? Thank you.
Yeah, that's an excellent question. So, where we talk about like tight underwear and warmth and so forth, usually has to do more with its impact on fertility. So the quality of sperm and so forth, because that raises the temperature within the testes, which can affect the quality of the sperm. I would say it has less impact on the prostate itself, where I tend to see, men with more prostate related issues, sometimes has to do with certain forms of work. So I'll give you a classic example. Somebody that is a truck driver, bouncing around, sitting in a chair, bouncing on that suspension all day, basically is, banging around on the prostate, for lack of a better term, which in turn causes inflammation, swelling, and can impact urinary symptoms and potentially sexually too, because of the nerves being alongside that prostate. So there are situations like that where arguably, it can impact the condition. Most men that have urinary related symptoms or erectile related issues have to do with just benign enlargement of the prostate, which happens in all of us as we get older, or other medical conditions that can impact, fertility and the quality of erections and the prostate itself. It's less so, from prostate cancer.
Okay. And I think the president would like to ask a question. Honorable BC Okoya. Please unmute yourself, ma'am. Yes, ma'am.
Blessings, blessings.
Blessings, ma'am. Blessings.
Thank you, Dr. Eric. Thank you for coming. We really enjoy your lecture, and I hope everybody gains some few things. So my question is, how early can men start doing the PSA testing? Since you said the early testing should be between 40 and 45, but
Yeah.
can men do it earlier than that?
Yes, excellent question. I would say in the African American population specifically, probably age 40 would be the earliest I would recommend. There hasn't been any evidence that earlier screening would be of much benefit. Again, understanding that the purpose of screening is to not only detect the disease, but to do it at the right sort of time frame or at the right point in time where treatment would be of benefit, and the treatment itself would carry a lower risk than the condition. And so what I'm trying to drive at with this is that, we've had large studies that have done autopsies on men that have shown at least a small prostate cancer in as many as about 20% of men, even in their late 30s, early 40s. But the thing is that at that stage in the game, it's in its earliest stages of development. And typically at that stage of the game, the rate of change in those very small cancers occurs over years, not weeks to months. And so the rationale with the early end of the time frame in terms of cancer screening is to do this where, we're still catching the disease early on, but not so early that we're exposing people to side effects of treatment unnecessarily. And so it's a long-winded answer, but I would say from age 40 onward would be the best choice.
Okay, thank you. Is there a potential treatment for it? And does surgery affect erection? That two questions together.
Yeah, so the key, in all of this, again, is finding the condition early while it's still within the prostate. The major treatments, without going into the weeds, but the major treatments in today's world are various forms of radiation treatment or surgical removal, which is robotic surgery. The harsh reality is that all treatments have the potential risk of affecting erections and impotence, but it plays out a little bit differently. So with surgery, the reality is that early after surgery, almost all men have loss of erections and impotence just from the surgery itself in removing the prostate, because the nerves that control erections are very delicate. They're right alongside the prostate. And in removing the prostate, we damage those nerves. So at the very beginning, almost all men have erectile problems, and the average recovery of erections takes about 1.5 to 2 years after surgery. The risk of impotence, loss of erections permanently after surgery, is about 35%. With radiation, this plays out differently. So it's a delayed side effect, such that at about 5 years from the time of radiation treatment, about 50% of men will have erectile problems. The other side effect of surgery is the risk of incontinence, loss of urinary control. In the days of open surgery, that risk was about 5 to 7%. So almost 1 in 20 men had that problem. With the robotic surgery, that risk is less than 1%. So it's pretty uncommon nowadays, actually, that we see that particular side effect.
But this question is 2.6 PSA safe at 74 years old? And
Yes,
what is the best food to take to avoid PSA?
Yeah, great question. So 2.6, I would say, is an excellent PSA at that stage in life. So that looks good. In terms of foods to eat, I touched on this a little bit. Lycopene, tomato-based products, vegetables, excellent. Hydration is important, keeping that urine as clear as possible. Multivitamin, standard men multivitamin would be my answer. So the best foods in terms of a natural diet, lean proteins, plenty of fluid, tomato-based products, I would say is the best recommendation I can give.
And can you explain a little bit on enlargement and how to treat that?
Yes, yeah. So enlargement by far and away is a very common condition that we treat. In the earlier stages of enlargement, and basically what I want to say here and sort of prefacing this is that enlargement is going to occur in all of us as we get older. This is mostly genetic in terms of what drives this. As urologists and as clinicians, we only treat people on the basis of symptoms. So it's really only when a point where that enlargement is causing urinary symptoms like a reduced flow or getting up at night more frequently or slowly emptying the bladder, where we begin to discuss treatment options. And in the earliest stages of that, there are medications, all of which are generic nowadays, that either relax the prostate channel to kind of open the pipe, if you will, or medicines that actually physically shrink the prostate over time. In patients that have more aggressive symptoms or problems, let's say with infections in the urine or blood in the urine, there are various surgical approaches that are minimally invasive, whereby we can open the channel from within. So it's not a complete removal of the prostate. It's certainly far less aggressive and less impactful than prostate cancer surgery, but it's a good way of opening the channel and resolving the problem completely.
And then before I take questions on the chat group, I think somebody is raising up. Okay, 2 people are raising up their hand. Honorable Patira, can you please unmute and ask your question? Honorable Bola Okoya, after.
Blessings. So,
Blessings,
so here's my question, and I've heard this in so many places. There have been some comments made about if you have sex regularly, it helps slow down the process of the PSA, I guess, number going up. Is this an accurate information or just maybe you can elaborate?
Yes, yeah, no, that's a great question, actually. So there are a couple aspects of this that I think are worth understanding. So, and I kind of joke around with patients that I'll write them a prescription, to have relations at home if they need it. But the truth of the matter is that having relations, having sex on a regular basis, actually does potentially help reduce the risk of prostate cancer. And the reason for this, it's kind of like a corollary, is that, by having relations, the act of ejaculation helps the prostate clear its channels, which in turn lessens chronic inflammation within the prostate. And there is research, actually pretty decent research, that shows that chronic inflammation may be a risk factor for prostate cancer later in life. So the answer to your question is, yeah, regular relations actually may be of benefit in terms of reducing cancer risk. And yeah, we would definitely recommend that. The only important point to understand, though, is that if you're going for a PSA test, you ought not have relations within 48 hours of having that blood test, or it may falsely drive up the result. So we ask patients to hold off on relations 2 to 3 days before getting blood work.
Blessings. My question is this. I just want to know if most of the members on this line listening to you and they want to get in touch with you, can the organization pass out the numbers or your information to them?
Oh, most certainly. If they don't have my information already, I'm glad to pass that on, of course. Yeah, thank you.
There is a question on the chat that says, what state are you and do you accept private insurance?
Yes. So I'm located both in New Jersey and Pennsylvania. My office is in Hopewell at Capitol Health, so just outside of Trenton. I have an office in Newtown, Pennsylvania as well. So I'm in both locations.
Is Honorable Fatai, I don't know if you still want to ask a question or?
Yes, please, just a small word. It's a very simple question, but I don't know if it is something I should ask on this platform. You know, there's some argument from courts or some quotas that says that some position of sex, like a woman riding on you, can give you trouble in terms of with your balls, and that can effectively go to have given you prostate cancer. Is there any position of lovemaking that can facilitate or make the chances of you having prostate cancer easier?
That's a good question. Honestly, no. In terms of particular positions, really no. In terms of its impact on prostate cancer, there are some positions where there's at least a little bit of a heightened risk of injury to the penis itself, which can affect the quality of erections over time. Specifically, sometimes having the woman on top actually could, in the right circumstances, allow the penis to be bent or torqued back in such a way that it can cause a bit of an injury to the penis itself and subsequently affect erections. But none of this would have a direct impact on prostate cancer. What I'm trying to say here is that it's actually the act of reaching climax and ejaculation that provides the benefit, regardless of how that's done.
Yeah, and Honorable Babatunde Basharon, I think.
Yes.
Go ahead, sir.
Okay, blessings. Can you all hear me?
Yes, sir.
Okay, blessings. To the doctor, I listened to the question one of my honorable asked you with respect to the frequency of sex as a deterrent to progression of cancer or cancer cells. Now, isn't that contradictory though? Educate us on the correlation between, because when you do have cancer treatment, post or prior to, once you have the active cells in your system, part of the suppression is to decrease your testosterone, which is your sexual drive and all that. So now, if it's helping to kill the cancer cells when you have the sex, then why are they using it to diminish your interest in sex or whatever? But understandably, cancer cells as well feeds from that, aside from sugar, when having sex. Because basically, when they're treating you to keep your testosterone down.
Right.
And that again, okay, then so help me there with that. Help me with that, please.
Yeah, great question. Actually, the reality is we're talking about a few different things here. So
okay.
What we're talking about in terms of sexual activity is for the prevention of developing prostate cancer. And the aspect in terms of its benefit really has nothing to do with testosterone at all. What I'm trying to say is that having relations really in no way affects overall testosterone levels. What it does, though, is it lessens inflammation in the prostate, which in turn, like any other cancer, lots of cancers are associated with chronic inflammation. By lessening inflammation, it lowers the potential risk of developing prostate cancer. Now, when it comes to the use of testosterone, or specifically medicines that turn off testosterone production, that's a method or a form of treatment that we use for advanced prostate cancers.
Okay.
So these are people kind of at the other end of the spectrum, that have aggressive forms of the disease already in their system, if not already outside of the prostate, where by turning off testosterone, we essentially make the cancer dormant almost instantly throughout the body. So these, unfortunately, are folks that are at the other end of the spectrum, well beyond prevention of the condition. They now have disease that's in other parts of their body.
Okay. Thank you, sir.
Yeah. I have Dr. Lukman raising up his hand. Please go ahead, sir.
Yeah, thank you so much. Hello, Dr. Mayer. Please permit me the opportunity to say congratulations to Eko Club of Philadelphia for this excellent medical awareness programs. I think this is the second or the third in the series. I missed the first one or two, but I'm glad I tuned in to listen to your discussion today on prostate cancer. I'm an internist. I'm based in Central Jersey. And again, I listened to the entire presentation, and I made some notes just to add. Again, I really benefited a lot from what you've been able to discuss with us today. And I'm glad that you're able to kind of clear some misconceptions about prostate cancer. I'm also glad that you're able to help me and maybe some other clinical providers on this forum about the confusion in terms of recommendations by different professionals. As you are aware, even including
very
your
much so.
American Urological Association and CDC and all that, which creates a lot of issues for people like us in trying to cancel our patient our PSA testing. And I think you're able to clear some of that confusion today, and I really appreciate that. And I appreciate the fact that you also talk about some of the modern approaches to diagnosis, including the MRI and also to the treatment of prostate cancer, including robotic surgery. One thing that you mentioned that got my attention, one of them, is the digital rectal examination.
Right.
As you are aware, again, there's been a lot of confusion about that. And a lot of us have been discouraged from doing rectal examination, which is some kind of a relief for somebody like me.
Yeah, especially as busy as you are.
I'm sure for
aside
you
from the
too.
test itself.
A lot of our male patients, they don't want to go there,
Yeah, fair enough.
They don't
Yeah, I
want to do
believe.
that, and that make them uncomfortable. So when this suggestion came about that you don't necessarily have to do rectal exam on your patient to screen for prostate, I was kind of relieved to some extent, even though I'm not sure if I was doing the right thing. I would like you to comment a little bit more on that to see somebody like me out there in the primary care setting. Is it really necessary for me to do that? And how should I discuss the issue of PSA in terms of shared decision making, as they call it, with my patients? Talk to them about when and what. Again, since there's been a lot of confusion about what to do or not to do, I'm hoping that maybe can give us some clarification on that decision. Thank you so much for having me.
These are excellent questions, and thank you, for that feedback as well. And getting to your first point in terms of doing a rectal exam as part of a routine physical, I tend to agree with the later studies suggesting that may not be necessary. So please understand that in the urology world, of course, I'm seeing a subset of men that are going to be at a heightened risk potentially of having prostate cancer. So from a urologist perspective, that does remain part of our overall routine in terms of doing that yearly. So I guess what I'm trying to say, or to best answer your question, that in terms of routine screening in someone who's otherwise asymptomatic, no family history of prostate cancer, I would say that the rectal exam probably could be avoided. Someone with urinary symptoms, strong family history of the condition, especially a family member perhaps that's deceased from prostate cancer, where it's safe to say they would have had an aggressive variant of it. I would suggest that consideration of the DRE in that specific setting, may be a good idea. So I think that's a kind of reasonable way to kind of balance this out in terms of finding that middle ground, and certainly would help, I think, immensely in your clinical practice in terms of reducing the overall number of those exams needed. And your other question, I think, also valid in terms of shared decision making, and this is why I kind of laid out the talk that I did. I kind of walk people through it the same way I did here today in terms of the rationale for the PSA test. I discuss a little bit about, the pitfalls of the test in terms of what it can and cannot answer, and its utility, so to speak, in terms of the circumstances of that individual. So as I gave that example earlier where, the guidelines say that typically you ought not screen someone beyond 70. Well, I still have that discussion with somebody who is otherwise healthy, longevity, greater than 10-year life expectancy, where that test may be of some benefit. I do the opposite too. I have patients sometimes, let's say in their early 50s, that have multiple medical problems, serious health conditions of other sorts, where unfortunately it's safe to say that they're going to be at high risk of mortality, from some other process where I may not necessarily do prostate cancer screening in that individual. So, I always tell people guidelines are guidelines that give us a good idea or a good sense of what, we ought to do. But it becomes then very patient specific, beyond that point.
Okay, I think Honorable Koya is still raising up his hand. Maybe you want to ask question. Please unmute. Yes, sir.
Blessings. I'm sorry, I have to release my hand. Thank you. I don't have
Okay. Honorable Fatah Adeniji, please go ahead, sir.
Yes, I have a quick one. Sorry for bothering you. Thank you for all this very nice, informative, and educative seminar you are giving us. My question is this: why is it that this prostate cancer issue is only for Africans and African Americans? Why blacks? Why can you give me why? Is it because we are black that we are having prostate? Because I've heard this so many times, but it's for black, it's for black, it's for black. Why?
Yeah. Excellent question. Yeah. No, that's an excellent question. And there are a couple of factors or things that are being looked at. First and foremost, it has to do with genetic makeup. So even though, today I'm discussing primarily African Americans being at heightened risk, the reality is that, and I hate to say it, I'm in this category too, where anyone with a first degree relative with prostate cancer is at a 30% higher risk of developing the cancer themselves. So in my case, my father had a pretty aggressive form of it. I have a much higher risk of developing this as well, simply because of our genetic underpinnings. The other aspect that has been looked at, specifically in the African American population, is that basal testosterone levels, so circulating testosterone in the African American population, tends to be a bit higher than other patient populations, whether it's Caucasians or Asians and so forth. And it's thought, or one of the theories anyway, too, is that, having that slight increase in testosterone may in some way impact the condition, because that serves almost like gasoline on a fire. It kind of accelerates the process, if you will. So there may be a couple components here in the African American community that, working together actually puts us at a higher risk overall.
I think we'll be taking just one question from the chat and one from Alhaji Mohammed. Let me go to the chat. He said, is there any correlation between having high testosterone and prostate cancer?
Yeah.
Is there any correlation?
Yeah, that's a good question. And again, it kind of ties into the answer I just gave, that, there is some research that suggests that having a chronically higher basal testosterone level may in fact increase the potential risk of developing prostate cancer over time. And a very simple way of putting it, this is really testosterone on the whole may not necessarily cause a prostate cancer, but it definitely stimulates it to grow more quickly. And it's that correlation, that ties into the characteristics of different populations as well.
Okay, so the last question will be from Alhaji Mohammed Aliru Bakar. Alhaji, please unmute yourself. Alhaji Mohammed, please unmute yourself.
Okay, assalamu alaikum. I really don't have a question, but I just want to take this opportunity to thank the doctor for a well-presented information to us this afternoon. I want to thank him for that. And I also want to thank the organizer and yourself for this opportunity. I think this is something that is very helpful to a lot of us, especially men, and because most of the time we tend to neglect about our health. I am one of them. I want to thank also Dr. Lukman for his comment. I will call him on the side, but there are a lot of things that we don't take advantage of, especially information like this. When it's available, we don't attend event like this because it is only when we get this information, we process it, it will be of help to us. So once again, thank you very much, Doctor, and thank you to all the organizers for this information. Thank you.
Thank you.
Thank you, sir. Before I call the president to give us there's one question here. Can LD 60+ man request prostate cancer screening from his doctor?
Most certainly, yes. Yeah, I'd recommend this, if you're going for a routine physical, for example, to have that discussion. Yeah, or at least to bring that up. Yeah. Most doctors, if you have that discussion, will easily add the blood test to the routine blood work that they perform.
Thank you very much. And President Olabisi Dabire-Okoya, please give us the remarks, for closing remarks. Thank you, ma'am.
Thank you, Dr. Eric Mayer. Thank you very much. We enjoy your lecture, and I'm very sure the men are more aware of the prostate health. Thank you for the lecture. So on behalf of Eko Club Philadelphia, we extend our gratitude to your outstanding presentation on the prostate cancer awareness. So your comprehensive approach to all the questions, answers is being taken, and I encourage everyone on this line to get tested, and they should all encourage their friends and family to be aware or to improve on their prostate health. So our next, the valuable insight and the practical advice that you have shared and the understanding empower us to take the proactive steps towards improving our health and well-being. So thank you again for the contribution, and may God help you. So Eko Club Philadelphia, we are a non-profit organization. We embark on different programs. We go to Ronald McDonald's. We give back to our community. We go to Homefront. We do free turkey drives. We do the free winter coat. And this is part of our health education. I hope when we call on you again, Dr. Eric, you can help us to bring some more topics for our awareness. So we have the Back to School initiative that we give scholarship. We give school supplies to underprivileged students. So thank you again, Dr. Eric. So, and our turkey drive. So I hope everyone enjoy all the lecture. Thank you very much again. So I'm going to call on everyone. No, I'm going to call on everyone to please donate to our cause, to our Back to School, the Thanksgiving turkey, the winter coat, the scholarship, medical mission, adopt a highway. So next month, not next month, December 7th, we are going to be presenting colon cancer awareness seminar. So inform your friends and family to please join us. Thank you again for joining. So I'm going to call on Honorable Tunde Basharon to give us our closing prayer. Thank you.
Thank you.
Blessings to all. Father, Lord, we thank you for this opportunity that you've given us today. More importantly, we thank you for giving our fellow Lagosians the fortitude to count this meeting worthy as it's been very, very informative. Health is wealth, they say, and this is a wealth of health that's been given us. Come and accept our thanks. As we take this information, let it be, I'm sure some of us can use it. A lot of men in our fold can use it to better themselves. We have to complete accept your thanks over this. You are God. You said that with you all things are possible. For those that are afflicted, I pray that with the information our doctor has given today, they can push forward and make preparation or to better themselves. Again, we thank you for this gathering. It's very informative. Father, Lord, accept our thanks. I pray.
Thank you.
Thank you.
Thank you very much.
Thank you, Honorable Basharon. I hope everybody enjoyed themselves with this lecture. Thank you again. So have a nice week, everyone. Thank you, Dr. Eric.
Thank you so much for having me.
So I'll talk to you again on the text and email. Thank you very much.
Thank you.
Thank you, everyone. Thank you for coming. So remember, December 7th, colon cancer awareness seminar. So it'll be coming up. Please join us. Thank you again. Thank you, Dr. Eric. Bye.